So yeah, just count to 3 and then start.
Good morning, everyone. My name is Roshan Prashant. I'm a third-year Doctor of Medicine student at UWA. As part of the scholarly activity unit in my medical school curriculum, I'm undertaking a 1.5-year research project, which I would like to present to you all today. The research project is titled Scheduling Metaheuristics and Artificial Intelligence for Reducing Radiotherapy Waiting Time, also titled the SMART Study. My supervisors are Dr. Suki Gill, a radiation oncologist at Sir Charles Gairdner Hospital, as well as Dr. Ebert, Dr. Roshan Farzad, Nathaniel, and Jake from medical physics at the medical physics department at UWA, as well as Ed Bailey, who is the head of radiation therapy at Charles Gairdner Hospital. So today I would like to provide you all with an introduction as well as highlight the rationale behind the project. And then I would like to delve into the specific elements of my research. And then to conclude, I would like to provide you all with an update regarding my progress at present and my plan for the upcoming months. So to start off with, radiation therapy is a mainstay in cancer treatment in today's world. Roughly 50% of all patients who are diagnosed with cancer undergo radiation therapy at some point over the course of their illness. And in fact, timely initiation of radiation therapy is strongly associated with good patient outcomes, specifically in the form of decreased rates of recurrence and prolonged periods of remission. In the context of radiotherapy, waiting time is defined as the interval between a patient being declared as ready for care by their clinician and the first dose of radiation therapy that is administered to the patient. The guidelines regarding radiotherapy waiting time were outlined in 2013 initially by the Faculty of Radiation Oncology. These guidelines were actually reinstated re-emphasized in the 2023 Radiation Oncology Practice Guidelines that were outlined by the Australian and New Zealand Faculty of Radiologists. So as per these guidelines, the standard good care requires radical, also known as curative radiotherapy, to commence within 14 days, and palliative radiotherapy to commence within 2 days. However, there is a period of leeway that is given, with the maximum acceptable waiting time being 28 days for radical treatment and 14 days for palliative care treatment. Waiting time data throughout Australia is recorded and made publicly available by the AIHW, the Australian Institute of Health and Welfare. This data was last published in 2018-2019, so in the pre-COVID era. And the AIHW, in fact, measures the 90th percentile waiting times as opposed to the average. So the waiting time that the AIHW publishes is the time in which 90% of patients commence their radiation therapy. So as per the AIHW data, the 90th percentile waiting time in WA for 2018 to 2019 was 34 days. This is in contrast to the national data when viewed as a whole, where the 90th percentile was in fact 27 days. And another point to note with the waiting time in WA is that this also exceeds the maximum acceptable waiting time prescribed by the Faculty of Radiation Oncologists. So just as I earlier mentioned that timely initiation of radiotherapy is associated with good patient outcomes, delays in radiotherapy is also associated with poorer patient outcomes. So delays in radiotherapy can cause tumor growth, prolong symptoms, as well as increase the risk of local recurrence, as well as from a psychosocial perspective, elevate patient anxiety as well. And so this highlights the fact that minimizing radiotherapy waiting times is a crucial aspect to providing good patient care and also to enhance patient experiences with the Australian healthcare system. The process of minimizing radiotherapy waiting times is known as the radiotherapy patient scheduling problem, or RTPS problem in short. Manually solving or manually finding timely solutions to the RTPS problem is quite challenging in today's day and age, particularly due to the growing complexities of the RTPS problem. The primary complexities are the limited number of resources, such as linear accelerators and CT scanners, in addition to the increasing number of cancer patients in Australia, which is a global trend, in fact. On top of this, additional factors such as alterations to patients' treatment regimen, as well as the fact that patients have to undergo multiple sessions of radiotherapy can also complicate the solving of the RTPS problem manually, at least. This essentially leads to a supply-demand mismatch, which increases the burden on medical staff and also is a source of stress for medical staff. In other industries where such a demand-supply mismatch has been identified, the field of workflow optimization has quite often come into play. Workflow optimization involves using a computational algorithm to optimize productivity. And this has been used across a variety of industries. Two pertinent examples that I would like to bring up today are the company NVIDIA, which develops graphics processing units, as well as SpaceX, which develops rockets. So these two companies use workflow optimization to enhance their productivity. A study by Zayan Kabas and colleagues tried to investigate the possible utility of workflow optimization in the healthcare system. And the authors actually concluded that this could help minimize staff burden, as well as enhance both the efficiency and the quality of healthcare that is provided to their patients. In addition, another study by Kapamara and colleagues was more focused on solving the RTPS problem itself. And the authors were actually able to represent the RTPS problem as a job shop scheduling problem, or a variant of the job shop scheduling problem known as a flexible job shop scheduling problem. Representing RTPSs as a JSSP or FJSP actually means that they're now compatible for the computational algorithms that are used traditionally in workflow optimization, meaning that now the RTPS problem becomes one that can be solved through computational methods. So this brings me to the crux of this research, which is that if we can find a way to solve a JSSP, in turn, we'll be able to solve the RTPS problem. So a little bit about JSSPs now. These are characterized by an n number of jobs that are completed by an m number of machines. And each job is separated into a set of operations. And every machine m takes a p processing time to complete every operation. If I were to represent this in a sort of tabular form, this is what typically a JSSP looks like. This also just happens to be the input that is put into the computational algorithms as well when solving JSSPs. Each number here corresponds to the processing time that it takes for a given machine to complete an operation that forms a subset of a greater job. The output from applying a computational algorithm to JSSPs is known as a Gantt chart, this chart here, whereby the machines comprise the y-axis and the time is on the x-axis. Each colored box here represents a job that has been assigned to a machine, and the length of the job is described or is characterized by how much space it takes up along the time axis here. In terms of solving or finding solutions to JSSPs, traditional methods have focused on mathematical modeling, which tries to identify an exact solution. What these mathematical models, an example of which is mixed integer linear programming, tries to do is represent the constraints in the form of a series of linear equations. And the model then looks to optimize all of these linear equations simultaneously. However, in today's day and age, where JSSPs are growing in complexity, most metaheuristics approaches are more so favored. And so metaheuristics approaches look for a good initial solution and then aim to iteratively improve upon this solution until a near optimal solution is identified. It's not necessarily the optimal, but it's close to. Pertinent examples of metaheuristics approaches that are relevant to this study in particular are Tabu Search, simulated annealing, and colony optimization. I have a graphical representation of a Tabu Search in this diagram here, where essentially it starts off with an initial solution and then applies changes to this, some of which may increase productivity, some of which may not increase productivity. That's essentially what this object function here describes. This means that it takes longer for the algorithm to complete the job. And essentially over the course of iterations, the goal of the Tabu Search is to find either the optimal solution or a near optimal solution. Simulated annealing quite closely resembles Tabu Search. However, it circumnavigates a major issue that does exist in some occasionally poorly formulated Tabu Search models, where there can be this cycling problem where the algorithm becomes stuck in a local minimum because going in either direction results in a decreased efficiency. So the model ceases to explore. Simulated annealing does this by including what's known as perturbations, particularly in early iterations of the algorithm. So for instance, while this might be a local minimum turning point that results in the cycling problem in Tabu Search. In simulated annealing, there's a perturbation that's added, which allows the model to accept less efficient solutions in the short term, which then actually allows the model to find the most efficient solution in the long term. Ant colony optimization is a slightly different approach to the first two, as this explores just the whole solution space, so the set of possible solutions, and assigns each possible solution with a pheromone trail value. This pheromone trail, a higher pheromone trail value is traversed more. And this is essentially what's represented by this diagram here, where if we say this is a possible solution, this trail has been assigned a higher pheromone trail value. And so the algorithm just explores this more, as sort of symbolized by the ants. In the modern day, metaheuristics approaches are preferred over mathematical models for two key reasons. The primary being that for any given JSSP, a metaheuristic approach actually requires a less processing power and hence is able to complete the task sooner than a mathematical model. In addition, for complex JSSPs, mathematical models can sometimes oversimplify the JSSP in the aim to try and represent all constraints in the form of either linear or quadratic equations. This problem is not encountered in metaheuristics models because they just look for a near optimal solution, not the exact one. Beyond metaheuristics, there is also a growing popularity to include artificial intelligence approaches to JSSPs. One such example is the genetic algorithm. This essentially looks at an initial population of solutions and then evaluates the fitness of each of these solutions as per a fitness function. A subset of these are preserved for the next iteration, while some are discarded on the basis of how well or how fit they are. Of the preserved functions, these then undergo a process known as breeding or reproduction, where different components of each of these solutions are combined with one another to form a new generation or offspring of solutions. The group of then parents and offspring undergo the same iterative process again and again. Genetic algorithm is unique because it combines both a metaheuristics approach as well as an artificial intelligence approach. Other forms of AI or subsets of AI include machine learning, and this is also an approach that is being used to solve JSSPs. The specific branch of machine learning is reinforcement learning. This encompasses both elements of supervised and unsupervised learning. Supervised because the training set and the testing set are selected by the programmer. However, the actual algorithm within each set is typically unsupervised. So it includes things such as neural networks and other elements of unsupervised machine learning. Examples of the RTPS problem being solved in healthcare, particularly through these sorts of computational optimization, is quite sparse. Although there are two examples that I would like to highlight. The first is by Zhang and colleagues in 2018, where they applied a genetic algorithm on top of a couple of other algorithms known as ASAP and just-in-time algorithms to try and solve the RTPS problem. This was applied on a simulated group of patients, so not a real subset or real cohort of patients. It was more so a hypothetical situation where there's 200 patients that require radiotherapy within 28 days. The study attempted to calculate the performance improvement through applying the genetic algorithm. This is how they calculated this through this formula, where T is referring to the tardiness. So tardiness means the number of days beyond the acceptable waiting time that it took for a patient to commence the radiation therapy. So it can be positive or negative. And the findings from the study were that there was actually a 6.53% performance improvement, particularly in the context of short form or short treatment radiotherapy. So that is patients who were scheduled for 5 to 15 sessions of radiotherapy. Another study in 2009 was more just purely a genetic algorithm, and this was in the Arden Cancer Center in the UK. And this study actually found that the waiting times were significantly reduced when using a genetic algorithm from 35 days, which was the control, to 16 and a half days for radical treatment and roughly 13 days for palliative care. So this brings me on to the aims of the research project that I'll be undertaking. The patient cohort that I'll be looking at is the group of cancer patients who were scheduled to undergo radiation therapy and who were declared ready for care from the period of January 2023 to December 2023 at Charles Gairdner Hospital. The objectives for this project are three-pronged, and Here's a graphical representation as well. So objective A will be to use the metaheuristics algorithm, so genetic algorithm, Tabu Search, and so forth, to produce a computational model that'll look to optimize the waiting times for this group of patients. And this is represented by this arm of the project outline here. Similarly, objective B will also look to optimize waiting times, but it will now look to employ a reinforcement learning model. And then to conclude, and time permitting, the third objective of the study is to use both models A and models B to conduct a cost effectiveness analysis to analyze the situation where to identify what sort of change there might be to waiting times if more resources or machines are procured. In terms of the significance of this study and studies on the RTPS problem in general, they're essentially two-pronged. The first being the research contribution that they could have. So representing the RTPS problem as a JSSP or FJSP, it's a relatively novel field, and I think this project could contribute to that research. And it could also facilitate future investigations to develop more sophisticated models that could actually further explore the applicability and functionality of this computational workflow optimization in the context of a dynamic healthcare setting, instead of just the control setting that this research project will be looking at. In addition, this research could also contribute in the field of healthcare in general, where future investigations in particular could help facilitate better quality of care for radiation therapy patients by finding a way to reduce waiting times and also minimizing the burden and stress on medical staff. This sort of decrease in waiting time could have the greatest positive impact in a state such as Western Australia, where the waiting times are systematically longer than the other states in Australia and don't meet the criteria set out by the FRO. In terms of the methodology, while I have mentioned the patients that will be included in the study, those who underwent one or more stages of the radiotherapy wait time process outside of Charles Gairdner Hospital will not be included in the study. Furthermore, patients with missing waiting time data or those who underwent emergency radiotherapy will also not be included. In terms of the control group and preliminary analysis, I will start off with a correlation analysis of the demographical and pathological data for patients and correlate that with their waiting times to identify the scope of the problem and to identify certain areas where the RTPS, where workflow optimization might most be needed. After this, the current waiting times for individual cancer patients will be recorded both incrementally and the total waiting time as well. So if I were to represent it sort of in a tabular format, this is what it would look like. So I would start off with each patient, and the ID would be de-identified, the age, gender, postcode, diagnosis, and whether they were undergoing radical or palliative care. And then on top of that, I would also like to include the number of days that it took for them to undergo each step of the pathway from being declared ready for care till the commencement of their radiation therapy. And in order to conduct the analysis, I will also require the number of CT scanners, treatment planning stations, and linear accelerators, amongst other resources at Charles Gairdner Hospital. The whole scenario will then be mapped to a JSSP on Python. This will be done, for ease of analysis, the whole data will be clustered into monthly blocks. So this will result in 12 distinct blocks, whereby a patient will be allocated to the block where they were declared ready for care. That is the month when they were declared ready for care. After this, the average waiting time in this whole JSSP will then be compared to the control data set, and the percentage improvement will be calculated using the formula that I had shown earlier. So essentially in part A, the genetic algorithm Tabu Search, simulated annealing, and colony optimization will be used. And through this, I look to calculate flow time. So that's a total make span, as well as produce Gantt charts such as this one here, and input a table like this. And then the best performing model in part A will be labeled model A, and this will be compared to the control. Similarly in part B, except it'll be just a reinforcement learning model that'll be implemented. In part C, to conduct the cost effectiveness analysis, I will require additional data. And so this will need me to also investigate the cost of new machines, the frequency of machine breakdown, as well as the number of staff per machine and approximate collective wages. In terms of considerations for this project, they are two-pronged. So firstly, regarding ethical considerations, all patient all patient information will be initially de-identified and then be provided to me for analysis to respect and maintain patient anonymity. Alongside this, all staff data will be either collective or average. So collective staff wages or average staff wages. This is so then no data point can be traced back to an individual staff member. And all of the analysis will be conducted at on-site computers at the medical physics department at UWA. Other considerations to also discuss are the fact that the Python programs or the Python packages that are available for solving JSSPs will likely need a significant amount of tailoring to ensure that they're compatible with the RTPS problem that I will be investigating. On top of this, there is also an element of self-directed learning here, partially due to the sparsity of easily available tutorials on how to solve JSSPs, particularly on Python, and especially using some of these more novel methods such as reinforcement learning and genetic algorithms. And finally, this whole project will also need to be managed alongside my concurrent MD studies. So at present, I'm working on an ethics submission to HREC at Charles Gairdner Hospital, and my literature review and oral defense, which are the assessments for my UWA course, they've been complete. I'm currently in the process of assessing each of the compatible Python packages and modifying them as required, and looking to solve sample JSSPs. Once ethics approval is obtained, I will look to procure the data that's required for the research, and the whole research period is from January 2024 to mid-2025. This is a timetable or a timeline project outline that I have developed, sort of starting from today. These are the goals that I've laid out. The aim is to complete the project by 28th of February, or somewhat around February next year. I've given a 3-month window to account for any challenges that may arise throughout the whole research process. And that's essentially my presentation. Thank you all very much for your time today. These are just my references, so this is where I obtained all my information from, and this is where all the figures are from. So thank you very much for your time. And if you have any questions, I'm happy to answer them.
Thanks, Roshan. Was there any questions for Roshan? Martin?
Yeah, thanks, Roshan. It's a really nice presentation. Very comprehensive. So when it comes to the optimization, what specifically are you optimizing? Is it wait time, average wait time? Is it wait time for a specific group? What would be the measure that you're trying to actually optimize?
So what I'm looking to optimize is the waiting time for each for the patients. Yes. So the thing is with these job shop scheduling problems, it doesn't particularly matter whether it's a hypothetical situation or a real situation. What's most important is what is the threshold. And so in this case, the threshold is 28 days. I could include a threshold if required for the model, or some of the different Python packages may just look to get a minimum waiting time altogether. But to sort of directly answer your question, yes, it's looking to optimize the waiting time for each individual patient.
So if you set that benchmark at 28 days, then the objective that you calculate might be like the sum of days in excess of 28 or something like that. Like if you had to choose the number that's going to represent how optimal your solution is, would that be a possibility? Or
so the number that I would use to initially at least describe to quantify that optimization, I'll show you, is on this slide. It's essentially the performance improvement. Right. So looking at TW will refer to the controlled data tardiness. So currently, how much in excess of that 28-day limit or 14-day limit, depending on how well the model performs, we are at. And then I will look at how that varies or how that compares to the specific kind of algorithm that I have applied. It's kind of like the percentage difference, but in the context of performance improvement.
Yeah. So this measure you're showing there, that's for an individual patient. Is that right? Or do you sum that over all the patients?
This would be for each individual patient.
Right. Yeah. So you might, the objective might be to minimize the sum of that over all patients.
Yes. The thing is, the thing that I guess has to be considered as well is that a lot of the tasks will be occurring in parallel to one another. So even though it may take 20 days for one patient and 14 days for the other, because there'll be a significant overlap, it may only take, it may all complete within 20 days because it'll be happening together. So it's more so about looking at the total duration for each individual patient and then calculating the average across all patients.
Yep. Okay.
Roshan, I just had a question. So with regards to the sort of broad task that you're trying to achieve, right? You mentioned that you're going to be conducting a sensitivity analysis sort of thing, right? Where the aim is to, for example, see if you simulate additional staff members, would that, increase or reduce the wait times, etc. Is the aim actually to predict like individual calendars for linear accelerators? Or is it to sort of like go even more granular than that and predict the calendars of individual staff members, if that makes sense? So like, yeah.
So what I would look to do is produce this Gantt chart. And in this, perhaps to sort of flesh this out in more detail, each machine here will represent every step along the pathway from a patient being declared ready for care till initiation of radiotherapy. So machine 1 might be the clinician appointment. Machine 2 might be the appointment at the CT scanner, or the machine 3 might be the treatment planning station. And so this would be somewhat like a calendar, as you were mentioning, for each of those individual steps along the pathway. So it would be perhaps, if let's say there's 3 CT scanners that are there running concurrently, this would be the timetable for CT scanner 1, CT scanner 2, and CT scanner 3. Does that answer the question?
That does. But then I guess like sort of when you progress past this stage of the research, right? And I assume the idea would be to test it in like a prospective setting, right? And see if it does actually improve the wait times.
Yes.
Would the intention then just be to like assign staff members to, each of these like calendar events, I guess, for each of these steps in the pathway so that they're optimized in that fashion? Is that how it would work in practice?
Yes, that is how I foresee it. That's what I see the next steps being, given that this first step is, or this first sort of proof of concept is successful. I think the next stage would be to try and implement it in clinical settings and look to integrate other things as well. So I guess from a practical standpoint, for every single staff member, they'll have their own timetable as to, okay, I'm at machine 1, or I'm at this CT scanner here for this duration on this day.
Yeah, okay, I get you. Probably the only other question I have then is that do you need to run this optimization problem, or how often do you think you'd need to run this optimization problem, right? Like, for example, if there was a sudden change in the amount of staff members that were sick, or something like that, or there was a new influx of staff members, or etc. Like, how often do you need to rerun this model to sort of do that process of assigning individual people to specific calendar events?
So as I understand, when it comes to solving job shop scheduling problems, there are dynamic variants that can be included to account for certain uncertainties or unprecedented changes to the timetable. So that is a possible solution where even though a staff member may be allocated to a certain subset of machines or a certain area for a specific period of time, there may be some dynamic nature involved within it. I would need to look further into that to answer your specific question as to how often it would need to reiterate. If I were to maybe provide my 2 cents on it, I think there might need to be a sort of commonly a dynamically updating version of a kind of program that that updates this timetable. Although the practicalities of that would need to be further explored in a sort of later stage of this of the study. I think the primary goal for this project is to first explore the potential utility of trying to implement workflow optimization in healthcare. Because yes, as you mentioned, one of the greatest challenges, particularly in the healthcare setting, is just the dynamic nature of it.
Yeah, okay. And I think probably the only last comment that I'd make is just that the reason that might be important is it depends on how long this optimization process takes to run, right? So if you need to run it on a pretty regular basis and it takes, 1 hour, then that's probably okay. But if it takes a week, that may not be okay. Or it might change sort of how you actually use it in clinical practice. But yeah, this is something to investigate later on. Thanks, Roshan.
Yes, and just regarding the processing time as well, I guess that's why those metaheuristics approaches are preferred over those over the mathematical approach, because during my literature review, I did come across some mathematical models that did try to quantify the radiation therapy, the RTPS problem. However, those were very extensive papers, and the actual process of coming up with even one schedule required the researchers to sort of outsource the work to external companies to try and come up with even one schedule. So it can be quite complex if a mathematical approach is done.
Yeah.
Whereas metaheuristic approaches, I think, are a little bit more compatible with that dynamic nature and do have a reduced processing time.
Yeah, I think that'd be a big point in favor of the metaheuristic approaches if they don't require as much computational expense, especially if you need to outsource it. That sort of indicates that it's pretty computationally expensive for those other methods.
Yeah.
Pedram, did
Thank
you
you
have
very much.
a question?
Yes, just very, very well present, very nice presentation, Roshan, well done. Have very quick recommendation. Do you think it's a good idea to have prediction of cure rate when you save the time for the patient, when you have a large cohort? So the impact of this timely treatment to the cure rate. So I know it's really hard to estimate or have some numbers to put as a statistics, but some investigation of what is the main reason for this. If at the end you save this level of time in terms of waiting, then how much you think you're going to save lives or better cure. Or the other thing is the cost. That's another thing. So if you have a timely cure or treatment, then how much you're going to save for the Department of Health or the patient base. So I know it's out of the scope of your project, but in the discussion, probably you can have a little bit of evaluation on this part and make it very relevant to both business managers and also for the patient in terms of cure.
Yes. Yep. Thank you very much for that suggestion, Pejman. Yes, I will look to certainly integrate that into the project. As part of the cost effectiveness analysis, I guess that might be somewhat of a component as well in the context of seeing just how much, because it'll be looking at the cost of procuring new equipment, but also the cost saved by reducing waiting times as well. So that would be a component of the cost effectiveness analysis. But along with that, sort of to address the point that you were mentioning about the major factors that contribute to waiting times in general, I tried to do a bit of a survey regarding this when looking at the AIHW data. They don't seem to highlight the specific or the main causes for each hospital. So that data is not yet available to me. But once the Sir Charles Gairdner data is provided to me, one of the first goals as part of that preliminary analysis will be, so in that table, I'll bring that up actually. So in that table, the number of days required by looking at the number of days required for each step, I also plan to calculate the average number of days for each of those steps taken in that waiting time period. And so that'll also help identify the main causes or the major factors for the delay in providing in commencing the radiotherapy. So yes, I'll include that in the discussion of my paper as well. Thank you very much.
Great. Thanks, Roshan. I think if there's no more questions, we can stop recording now. Well done.
Thank you very much.